Hello and welcome to Ask Dr. Mingle, a Q&A series where we take your questions about quality programs and the transition to value-based care. I am Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle.
We have 3 great questions today, but before we get to that, I want to invite our listeners to send us their questions for Dr. Mingle. You can leave your questions in the comments section below this video on YouTube, or you can send us an email at hello@minglehealth.com. When you send us an email, be sure to put Ask Dr. Mingle in the subject line. I'll be checking for your questions there, and Dr. Mingle will pick a few of his favorites to answer each episode. Okay, let's jump into the questions. All right, first question today, Dr. Mingle. Marilyn asks, could you explain how individual measures impact cost calculations? The colonoscopy measure, for example, is preventative. Does that change cost calculations at all?
Well, thanks, Kyle, and thanks, Marilyn. Great question. Every cost measure is unique, so it's the colonoscopy measure is not does not function at all like any of the others. There's a set of things that make each cost measure unique, and that's reflected in the specifications that you can find on the qpp.cms.gov website. Every cost measure is defined by a set of triggers. And a trigger is a CPT event, sometimes defined as well by a set of ICD diagnosis limitations. But when Medicare receives those, it triggers a cost measurement for the type. Then there's attribution rules. That is what clinicians can be attributed cost for these. So not everyone can be eligible for every cost measure. Then there's a list of services that are attributed to the total cost of the procedure. So additional CPT and or ICD, with or without ICD codes, that get attributed to that episode, and each of these has a time frame. That if that code shows up in a bill to Medicare within a certain time period after the trigger event, then that can be included in the cost calculation. And then there's certain things that can be excluded, again, divided by or indicated by CPT ICD codes, services that they don't care to track. And then there's each in the specifications, there's a set of risk adjusters, that is what characteristics, again defined by CPT and ICD codes, what change the episode cost dynamics enough that they should be included as adjusters. So all these are listed. You can find them on the qpp.cms.gov website. They're a little bit dense and difficult to understand, and you can also on that site find some overview documents that help as well. But again, just remember that every cost episode has unique specifications. None of them, although they are the same in the characteristics I just described, within those characteristics they differ dramatically. So your colonoscopy won't be measured at all like any of the other cost episode measures.
Great. Thanks for the question, Marilyn. And I was going to mention that on the Mingle Health website, you can find a webinar that Dr. Mingle did all about costs. It's a deep dive into cost, and it has a bunch of great information about cost in it. So be sure to check that out. Our next question today is from Polly. And Polly asks, if a measure doesn't have a benchmark, how is it scored?
Well, Polly, great question, and thanks. You're aware that the majority of quality measures, and I'm assuming you're talking about quality measures, not cost or promoting interoperability or practice improvement. In the cost measure that's been around for a while, we look 2 years back and use the submissions of those measures to benchmark the current year performance. If there isn't a benchmark from 2 years ago, and that may be because there hasn't been enough volume of those measures to establish a benchmark. It might be a new measure, or it might be an old measure for which the specifications have substantially changed. In any of those cases, we don't have a valid benchmark from 2 years ago on which to score those measures. Now, in those cases, Medicare will calculate a benchmark from that submission year data. So for this year, we're in 2022 data. By the end of the submission period, roughly March 31st of 2023, Medicare will look at each of those measures that don't have a previous benchmark. And if there's at least 20 entities, that can be an individual, a group, a virtual group, any entity that submits that measure, there has to be at least 20 unique submissions of that measure. Each of those 20 submissions come from an eligible entity or clinician. Each have meet the data completeness criteria, and each in themselves have at least the floor of 20 unique cases to submit. If there's that minimum standard, Medicare will calculate a benchmark from the current year data and then apply that just as it does the historical benchmarks to the measurement. This is in fact a more accurate way to grade on the curve, if you will, or divide the industry into deciles or percentiles. But it doesn't give us that advantage that we're looking for, that we know what the standard is. If we submit this number, we know we're going to get this score. We'll still get a solid score if there's enough data to judge that on. But it can only be judged after all the data is in and analyzed.
Excellent question, Polly, and thank you for sending it in. Our last question today is from Anne, and Anne asks, our practice is switching to a different EHR system this year. How will that affect our MIPS submission?
Great question, Anne. A change of EHR certainly creates some challenges. It can affect the data completeness criteria, rendering a submission invalid. And it can dramatically affect your performance levels from changes in documentation and query standards, even if your performance hasn't changed, your true performance hasn't changed. So on the data completeness criteria, to the extent that your patient panel doesn't all have data in the new system, you may not be reporting on all of them, and that can be a failure of data completeness. And that's whether you choose the original EHR or the new EHR to report from. Neither will have a complete set of data, and both then will have some potential failures of data completeness. Now, if 70% of your patients are reflected in either the first or the second, that could be a valid submission from a single one of the EHRs for that year. And in performance, you might get hit in either of two ways. One, if you don't have access to the performance data on one platform for all of your patients, then your parent performance may be quite low, even though your real performance is higher, or the documentation protocol in this new HR is different. You might not be as good at it, or even if you know exactly where it should be put, those fields may not be captured appropriately in the reports, and therefore hurting your performance. So there's two solutions generally to improve that. First, migrate the data from the old EHR to the new. That means that everything you've done in the past is reflected in the new EHR. A single submission from that EHR will suffice to both hit the data completeness criteria and your performance criteria. Now, many people don't choose to migrate the data when they're changing EHRs. They instead keep an archive version of the old EHR available that they can get the data from, and finding it not cost compatible. It's cost prohibitive, in fact, to migrate the data. If you haven't migrated the data, then your best alternative solution, again, if there's at least 70% of your data is in one, you could do a single submission from one of those with some mathematical hazards to watch for. But I think our methods of submitting data handle that quite well. So if you're using us, we can easily take your data from both systems, combine it, and put it out as a combined submission. And it doesn't work to take your two EHR submissions to generate the ECQMs from both and put them together. Medicare wants those patient populations blended and deduplicated. And so you can't just take the QRDA3 scores and add the numerators and denominators. But in our methodology, we'll take a download from each of those and big raw data sets with the performance data embedded and the patient identifiers embedded. And it doesn't matter how many EHR systems you have, we can put those together. And that can work both as well for practice that changes EHRs in mid-year, as well as in other organizations, ACOs or group data submissions in which there are multiple EHRs in the group that's submitting together. It's our systems are designed to take as many data feeds as necessary to create that single submission. So we can help with that. And of course, knowing that any EHR has all EHRs have problems with data integrity, even if it reflects well in the visit note and your look back at what happened in every visit. Not always is the data available to your query tools, and therefore. Watching your data throughout the year is quite important, and our more aggressive clients will drill through their data periodically. It might be monthly, it might be quarterly, maybe only twice a year, but they'll look at that data. They'll collect a sample of patients who fall into the performance met, performance not met, and audit those a handful of those charts to make sure that the query is appropriately capturing the data that puts patients in those areas. So we're delighted. That's how we're designed to work, and we're delighted to help you with that. So give us data early, measure often, audit to make sure the right stuff is getting through, and you've got all your templates and your database set up appropriately.
Yeah, so far that's our motto here on Ask Dr. Mingle is measure early, measure often. So Anne, Polly, Marilyn, thank you for your questions. We appreciate you sending them in to us. And for folks listening, if you have questions for Dr. Mingle, please send them in. You can send them directly to us via email. You can send those emails to hello@minglehealth.com. And when you do, make sure you put Ask Dr. Mingle in the subject line. You can also leave your questions in a YouTube comment, and you can also connect with us on LinkedIn with your questions. Thanks, Dr. Mingle, for sharing your expertise and insight with us today.
Thank you, Kyle.
All right. Thanks, everyone, and we'll see you next time on Ask Dr. Mingle.